So today's topic will be smoldering myeloma, what we know and where we're going. We chose this topic because it was highly requested, as I mentioned earlier. And yeah, and we want to know what we have now, what we know, what are the future of MGUS and smoldering myeloma looks like, and some clinical trials that we'll talk about in more details later. So I want to introduce our speakers, Dr. Kazandjian, clinical and translation and research interests lie in the treatment of precursor plasma cell disorders, including high-risk smoldering multiple myeloma and the role of immunotherapy in plasma cell dyscrasias, I think. In addition, he is reevaluating the role of autologous stem cell transplant in the era of a highly efficacious novel drugs, immunotherapy, biologics, and cell-based therapies with the hypothesis that certain subsets of patients with myeloma may not be benefited by the default SCT. Kellye Koubeck is an advanced practice registered nurse at the University of Miami Sylvester Comprehensive Cancer Center. Currently, she serves as a research advanced practice nurse at the Sylvester Myeloma Institute, specializing in plasma cell disorders. Beyond her clinical duties, Kellye actively contributes to the advancement of medical science by serving as a sub-investigator for interventional clinical trials, playing a crucial role in the implementation and development of research trials and facilitating the dissemination of clinical trial findings. So I'll turn the time over to them so they can talk about our topic.
Thank you very much, Marisol, and thank you, for HealthTree and all for inviting us. It's a pleasure to be here. This is a topic very near and dear to me. I've been focusing on this for almost 15 years. For those who may not know, I'm currently obviously at University of Miami. Prior to that, I was at the NCI and spent some time at the FDA also. And so my interests are really obviously plasma cell disorders, but in particular precursor diseases and drug development as a whole. I'm not sure about the audience, but I'm sure there's very well-educated and maybe some that are just finding out about smoldering myeloma. So I wanted to sort of give a brief overview about smoldering myeloma and the plasma cell disorders. So what is a plasma cell? It almost sounds science fiction a little bit. So a plasma cell is a type of immune cell. It's from the B cells. It's a B cell lineage. Some B cells, after they mature in the lymph node, as part of the normal maturation process, sort of go out and get even more differentiated to be a plasma cell. So a plasma cell is like a B cell, except its primary role is to make antibodies. So they make antibodies to help you fight off infections, parasites, other tumors, etc. Obviously, a more recent, which we'll get later, but we've actually, as scientists and physicians, been able to interrogate that whole antibody sort of system that the body normally uses in order to make drugs with them, in order to activate our own immune cell to kill tumor cells. But anyway, going back, so those are the plasma cell disorders. So they come from plasma cells. When something goes wrong with a plasma cell in the DNA, it causes aberrations in the DNA or mutations. And that's when you have an abnormal plasma cell, or one could think about it as a myeloma cell. But just because you have an aberrant or abnormal myeloma cell doesn't mean you have multiple myeloma. And again, it's a spectrum of disease. And as many of you know, sort of the first hint of abnormal plasma cells is given the diagnosis of MGUS. So MGUS or MGUS stands for monoclonal gammopathy of undetermined significance. Now, it was coined MGUS because initially people were found to have these who were otherwise didn't have any symptoms, and we really didn't know what to make out of them. That's why it was called undetermined. It was about a decade or so later that studies were done to actually show that, yes, these abnormal plasma cells found in MGUS maybe could be a precursor condition to the full-blown blood cancer multiple myeloma. So we diagnose MGUS when patients have these abnormal plasma cells. They have to be less than 10% in the bone marrow when you get a bone marrow, and less than 3 grams per deciliter in the monoclonal protein. Then you would have MGUS. So sort of if you think about the spectrum, the next thing after MGUS is smoldering myeloma. So smoldering myeloma clinically in the old days used to be called asymptomatic myeloma, meaning, again, you have no symptoms, you don't know you have blood cancer, it's detected just in your blood or in your bone marrow incidentally. And MGUS and smoldering myeloma really clinically or share a lot of the same characteristics in terms of really being silent. But what differentiates the two is sort of the amount of abnormal plasma cells. So in smoldering myeloma is when you have more than 10% plasma cells. Or if your monoclonal protein is 3 grams or more in your blood. So that's smoldering myeloma. So when does smoldering myeloma become multiple myeloma? Just one thing to say is it is a spectrum and there's a natural transition, but to develop multiple myeloma doesn't mean you have to have a smoldering myeloma phase, meaning sometimes in some patients, MGUS can convert into full-blown multiple myeloma. But what really makes multiple myeloma the blood cancer, or in the old days, symptomatic, meaning with symptoms myeloma, is when you have end organ damage. And that end organ damage is luckily, it's an easy term to remember. It's called CRAB, C-R-A-B. It's when you have high calcium, for the C. R stands for renal or kidney failure. A stands for anemia. And B stands for bone destruction or osteolytic lesions in the bone. And so you have, again, to recap, you have MGUS on the one end, you have multiple myeloma on the other end, and you have this entity called smoldering myeloma right in the middle. In the old days, prior to 2014, CRAB criteria, for the most part, is what differentiated, like what I said. However, there were patients that had very high numbers, not CRAB criteria, but very high numbers diagnosed with smoldering myeloma in terms of the light chains, which is something that these abnormal plasma cells secrete, or with certain findings on MRI, or that percentage of plasma cells in the bone marrow being 60% or more. And so those patients were kind of considered ultra high risk smoldering myeloma, which wasn't a great term. And those patients were called that because based on other studies, independent studies, showed that patients who had those criteria had somewhere between 70-80% risk of developing the full-blown blood cancer multiple myeloma in 2 years. And so no one really likes to wait until you actually have the organ damage in order to have the diagnosis. Now, one could argue this is just semantics, but the semantics is very important because it's what triggers treatment. So smoldering myeloma, the standard of care for the most part, it is no treatment, and multiple myeloma is treatment. However, we all in the community felt like if you have those high-risk features that previously were known as ultra high-risk smoldering myeloma, you really have stage 0 or early stage multiple myeloma, and that kind of triggers treatment. So that's why those distinctions are kind of important. Now, if you have MGUS or smoldering myeloma, doesn't mean that you're going to have multiple myeloma. However, patients who, like I said previously, large-scale studies have been done with over 70,000 patients from the NCI registries that all patients with multiple myeloma at some point in their past had an undetectable or detectable MGUS, just didn't know about it. And so one could argue, if we have a precursor cancer or a precancer, why wouldn't we do treatment, especially smoldering myeloma? Well, in the old days, there were a number of studies. When I say old days, probably in the 60s, 70s, early 80s, there were studies done when we didn't have great therapies for multiple myeloma in the treatment of smoldering myeloma. And really and that was mostly cytotoxic chemotherapy. And what we found in those series is where the toxicity just didn't justify the benefit, which was marginal in treating smoldering myeloma. But those are not these days. These days we have a lot of great treatments. And of course, this question about treating smoldering myeloma is really reopened. The other important thing about smoldering myeloma is, again, is the risk of changing into full-blown myeloma. So what is that risk? Well, there have been different institutions and people who have kind of looked at their series of smoldering myeloma to try to come up with sort of a prognostic model. And there are prognostic models. There's quite a number of them, actually. There is, I think it was about 2007, the Mayo Clinic came up with a model. Around the same time, the PAFIMA, or the Spanish group, came up with a model where they basically made three categories: low, intermediate, and high. And if patient had certain disease characteristics, it would be lumped into one of those, and you could actually guesstimate, how, what the risk and when the risk of progression was. And then more recently, obviously, as many of you know, there's the 20-20 criteria by the Mayo Clinic and the IMWG criteria. The reality is it's nice to have models, but they're just models. And in fact, I did a comparison when I was at the NCI of the different models in our patients, and they're unfortunately highly discordant, meaning you could be low risk based on one model and high risk on the other. So as a patient, like, what do you do? It's like very difficult. Which model do you use? Well, first of all, I think the reason why those models are so discordant they're based on sort of snapshots and when the patient gets diagnosed. And obviously we don't go routine screening for this. So someone could have incidentally been found to have the smoldering myeloma 10 years before or 10 years after they first had it in their blood. It just was never tested. And someone else could have it in a year. And really, a lot of these models are just based on how much or how many myeloma cells are in the body, but not necessarily the tempo, meaning how long did it take to get there? What is the aggressiveness of that particular smoldering myeloma? So really, I think our group at Sylvester, we in the Myeloma Institute, we really kind of want to hone this down. We believe the key is in the genomics of this. And so our group is highly studying, the blueprints sort of these smoldering myeloma patients and trying to figure out which one are really at high risk, right? So what does the future hold in terms of treatment? I think, we always try to figure out what treatment, or should we treat smoldering myeloma? And most of us start off with high risk smoldering myeloma. But, I think that question is going to change probably. It's not so much of a question of which smoldering myeloma patients to treat, but rather I think it's probably more appropriate to think of smoldering myeloma as kind of this like middle ground between MGUS and multiple myeloma, meaning some patients diagnosed with smoldering myeloma will actually live a life that's more like an MGUS patient. And on the other hand, a subgroup of people with smoldering myeloma may have a faster tempo and really just got diagnosed earlier. There are just inevitably to have multiple myeloma. And so at some point, based on genomics, if we can actually get rid of that middle smoldering myeloma category, it would actually make life easier, because then based on genomics, if we could say, this is the future now I'm talking about, if we could say, based on your genomics, you're like 99% chance of having, early stage or stage 0 multiple myeloma, then the treatments wouldn't be so important because we would actually just extrapolate whatever we treat multiple myeloma with, right? So we are already, studying multiple myeloma, newly diagnosed multiple myeloma in depth with the different treatments. You could easily just move those over. So just one more thing, I think we can transitioning more into treatments. Number of treatments, again, in the early days, were kind of really didn't justify the benefit risk. But really the question reopened with the introduction of the novel therapies. And as many of you know, sort of the first thing to show this was the lenalidomide treatment on a randomized phase 3 study done by the Spanish group. It was confirmed by the Americans in our cooperative group study. But meanwhile, as the readout on that takes a very long time because patients, it's a good thing, patients live very long. The whole field had already moved to 3 drugs and like 4 drugs. So the question is, if you're going to treat, how do you treat? So the practical part of this is in my clinic, I believe if you have high risk smoldering myeloma based on some of the characteristics that we know in the models, then clinical trials is the number one thing to do. And clinical trials is really not agreeable or can't do it. I think observation, which is what the mainstay is what to do. I personally don't treat smoldering myeloma outside of a clinical trial. I don't think we capture enough data, and I don't think any of the studies have kind of justified that yet. I can tell you a little bit about the studies that have treated it. So we had the NCI, we had a single arm study, meaning everyone got the same treatment. That treatment was a 3-drug therapy called KRD. So K stands for Kyprolis, R stands for Revlimid, D stands for dexamethasone. And patients with high-risk smoldering myeloma were treated with 8 cycles of that treatment, followed by 2 years of maintenance lenalidomide or Revlimid. And our deep responses, meaning a minimal residual disease negative responses, were fairly high in the 60% plus range. And patients were going for a long time. The majority of patients at 5 years hadn't developed full-blown myeloma. Of course, there's caveats, and it's not the magic regimen. But a lot of these other studies have shown similar findings. And again, sort of treating smoldering myeloma kind of goes in parallel to all the new discoveries in the treatment of newly diagnosed multiple myeloma. And really, immunotherapies has been the highest point, in our drug development, as many of you know. And those come in usually 2 flavors, the chimeric antigen receptor T cells, or the CAR T cells, and the bispecific T cell engagers, sometimes known as bispecific antibodies or BiTE therapies. And these current studies are really exciting because they're really interrogating the immune system to see if since these drugs work so well in the relapse refractory setting, how do they work in the smoldering myeloma setting. And so I just wanted to give a brief introduction about smoldering myeloma before I hand it off to my colleague. Again, at Sylvester, we have a very active multiple myeloma clinical trial enterprise. We have about 19 trials, I think, is the most recent count. And we do have a couple of smoldering myeloma. This one that Kellye will present to you is particularly exciting because it's the immunotherapies that I'm discussing. And it is actually, what's really important for those who don't know, there's 2 major types of clinical trials. One is investigator-sponsored and one is industry-sponsored. The difference is investigator-sponsored is when the doctors, the attendings, the physicians themselves actually write the protocol. They have an idea, they have a hypothesis themselves, and they think of it, and then they have to go and kind of guarantee the monies to be able to run that trial and the drugs, etc. So our immunotherapy trial is actually one of those investigator-sponsored trials. And with that, I will hand it off to Kellye so she can tell us a little bit about the REVIVE study. Thank you.
Thank you, Dr. Kazandjian, and thank you, Marisol, for the introduction. So my name is Kellye. I'm one of the research nurse practitioners or APRNs at the Sylvester Myeloma Institute at University of Miami. I work alongside Dr. Kazandjian and our other myeloma physicians. I primarily see patients that are enrolled to our clinical trials. So that is my area of expertise. Prior to this, I've been with Sylvester for about 1.5 years now. And prior to this, I was a clinical trials nurse at Memorial Sloan Kettering in New York City for a long time. So my background for the past 8 years or so has been specifically within the realm of research and clinical trials. And I'm going to just share my screen briefly. I have a couple of slides prepared for you guys about our REVIVE trial. So let me just share this briefly so you guys can see. Okay. Is everyone able to, can we see the screen? Yes, okay. So this is our REVIVE clinical trial, which is a trial that opened a couple of months ago here at Sylvester University of Miami. It's a very exciting clinical trial option that we have available for our patients that have high-risk smoldering multiple myeloma, as Dr. Kazandjian had spoken about. So this trial specifically, I'm going to go into the details, but it's teclistamab or talquetamab in combination with daratumumab for patients in high-risk smoldering multiple myeloma. Okay, so just some background on this. You can see on the table that I have here on the right, this is the diagnostic criteria for multiple myeloma and the precursor conditions with which Dr. Kazandjian had touched on. So if we think of these conditions as on a spectrum of plasma cell disorders, you have MGUS, you have smoldering myeloma, and then you have multiple myeloma. And this table kind of differentiates the basic diagnostic criteria for each. I'm going to focus on smoldering myeloma for the purpose of this presentation. But for patients that have smoldering myeloma, so they have the presence of greater than 3 or greater grams per deciliter of serum M protein or M protein within the blood, or greater than 10%, greater than or equal to 10% plasma cells within their bone marrow biopsy. So if we were to do a bone marrow biopsy, we would see 10% or greater plasma cells. But they have the absence of any of these myeloma-defining events or the CRAB features that Dr. Kazandjian had mentioned, meaning that they do not have any of these events or criteria that would place them into the multiple myeloma risk category. So when these patients come to us, one of the things that we do is we do risk stratify them using some of the approved models that Dr. Kazandjian had mentioned. The Mayo and the Spanish Prathema risk criteria are 2 of the approved models that we use to risk stratify them. And what I mean by that is determine whether or not these patients are low, intermediate, or high risk. And that risk is risk of developing the end organ damage or myeloma defining event that would place them into the category of multiple myeloma. As standard of care, we don't traditionally treat smoldering myeloma, and the reason being is a subset of these patients will never develop multiple myeloma. We can continue to watch them, and they will never develop the organ damage that would place them or upgrade their diagnosis to multiple myeloma. However, we know that the patients that are considered high risk have a much higher likelihood of eventual progression to multiple myeloma. So what we know is that greater than or equal to 70% of high-risk smoldering patients will eventually develop multiple myeloma, and the median time to progression for these patients is 24 months or 2 years. So we know that the majority of these patients will eventually develop multiple myeloma. So what this means is that we really want to develop and study these therapies that can attempt to stop that transition essentially from multiple myeloma, and that's to multiple myeloma. And that's what the goal of this REVIVE trial is to identify and treat multiple myeloma at an early stage in the hopes of developing what we call a functional cure for patients that have high-risk smoldering myeloma. Okay, so the treatment regimen for this trial, so I'm going to focus specifically on two of the drugs that are listed here. The drug has both, or the trial has both teclistamab and talquetamab. Right now we have the arm open, that's teclistamab with daratumumab. The plan is to enroll, the way the study is written right now or designed right now is to enroll a number of patients to that arm, and then eventually there will be an arm open with talquetamab. But I'm going to talk more, I will talk about all three, but I'll talk primarily about the arm that we have open now, which is teclistamab and daratumumab. So teclistamab is a BCMA bispecific antibody. And what that means is it targets BCMA, which is a protein that's expressed on the surface of myeloma cells. So it targets BCMA as well as CD3, which is on the immune system's T cells. And it essentially forces the cell to recognize the myeloma cell and attack and kill them. And this drug, so teclistamab, was approved in October of 2022 for the treatment of relapsed refractory multiple myeloma in patients that have received at least 4 prior lines of therapy. So this drug is approved for patients that have multiple myeloma in the relapsed refractory setting, so that have had exposure to several prior lines of therapy and are now requiring a new line of therapy. Teclistamab is also a bispecific antibody. This is a GPRC5D bispecific antibody. So it works in the same way that teclistamab works, but the target, instead of being BCMA, is that GPRC5D. But it essentially works in the same way, targeting that on the myeloma cell, as well as engaging your body's immune system, the T cells in the immune system, to attack that myeloma cell. Talquetamab was approved in August of 2023, also for relapse in the relapse refractory setting for patients that have had at least 4 prior lines of therapy. And then daratumumab is a CD38 monoclonal antibody. So this attaches to CD38, which is commonly expressed on the surface of myeloma cells. It binds to the CD38 protein and essentially marks the cell for destruction by the body's immune system. Daratumumab was approved in November of 2015. This was when it was initially approved for the treatment of multiple myeloma. At the time, it was approved for patients that have had at least 3 prior lines of therapy. Since that time, we are now able to give it upfront for newly diagnosed patients in combination with other therapies. And we also commonly give it a second-line therapy for patients at first relapse that have multiple myeloma. So the arm that we have open, like I said, there are 2 arms on this study, teclistamab and daratumumab, and that's the arm that's open right now, and then talquetamab and daratumumab with plans to open that arm down the road. So the teclistamab and daratumumab arm, this is just kind of a general on the right here, a general outline of the treatment plan. It's given on 28-day cycles. We follow the standard of care dosing for both of these medications. So teclistamab is given as step-up dosing, meaning you get a small dose and then another small dose before you get the full dose. So you get the initial dose on day 1 and then day 4 and then weekly from that time moving forward. It's given as a subcutaneous injection in the skin. And then daratumumab is also given as a subcutaneous injection in the skin. And the way that's given is it's given weekly for the first 2 months of treatment, and then it's given every other week, and then eventually it's given monthly when you get to cycle 7 of treatment. And so with this REVIVE trial, these drugs are given in combination on this schedule outlined for a total of 24 cycles of treatment, which is 2 years. And this is just the study design again. So the eligibility is outlined over here in green. I'm going to go over some of the inclusion and exclusion on the next slide. So I'll touch on that in a little bit more detail. But essentially, when patients are identified as potentially being eligible or they express interest in this trial, the process is similar to our other clinical trials. We present this option to patients if they're interested and we think that they would be eligible. Then they come in, they sign consent to participate in the trial, and then they undergo screening and baseline evaluations. And this includes, basic blood work, an EKG, to assess organ function and just make sure they're fit to participate in this clinical trial. It also includes a bone marrow biopsy, a PET CT, and a whole body MRI. And these are all very important for us to obtain at baseline, because what we don't want to do is we don't want to treat a patient on this study that has multiple myeloma. We want to make sure they are in that high risk category and they have not crossed over to a high risk smoldering category, and they've not crossed over to multiple myeloma. The goal, the target, the target group of patients for this study is high risk smoldering. So if we find anything on the blood work, the bone marrow biopsy, the PET CT, or the MRI that would place them into the multiple myeloma category, then they would not be eligible for this trial. We have other trials available for patients that are newly diagnosed, but this we're focusing specifically on high risk smoldering. So once they've been deemed eligible based on that baseline screening evaluation, they will start treatment. And then they're treated, like I said, the study is written for a total of 24 cycles or 2 years of treatment. You can see there's time points that are outlined here. It looks like it's annually, where we're getting bone marrow biopsies. We're doing MRD, or minimal residual disease testing, which is a highly sensitive test that we can do that can detect a myeloma cell at a level as low as 1 in a million cells. We do that typically when we do bone marrow biopsies and PET CTs. So we're doing those assessments annually, and we're comparing them to the baseline assessments that the patients have to gauge their response. And then once they've completed the 24 cycles, then they've completed the study. They are then followed at that point and follow up. And then the study inclusion or exclusion criteria. So I think one of the things that makes this trial unique is that it accounts for patients that are high risk smoldering by the approved models that I spoke about, which is the Mayo and the PATHEMA, the Spanish PATHEMA. But it also allows for patients that are considered high risk by other features that are not accounted for within these models. And I'll go through each one of those kind of specifically. But the basic study inclusion exclusion criteria, they have to have, of course, smoldering myeloma based on the International Myeloma Working Group criteria. The presence of any sort of myeloma defining event or CRAB criteria, as I said before, would exclude them. That would upgrade their diagnosis to multiple myeloma, and it would exclude them from this high risk smoldering trial. And then patients can be categorized as high risk by a number of different ways. So there's the PATHEMA, or the Spanish model, which is an increase in the number of abnormal plasma cells in the bone marrow, plus the presence of immunoparesis, which just means the reduction of one of the levels of the immunoglobulins in the blood. So if they're high risk based on that criteria, then they would be eligible. If they're high risk based on the Mayo 2220, so Mayo 2220, this assesses for 3 independent risk factors for progression. So the first 20 is 20% bone marrow plasma cells, so greater than or equal to 20% plasma cells in the bone marrow biopsy, an M protein in the blood of greater than 2 grams per deciliter, or a free light chain ratio of greater than 20. So based on these, patients can either be considered low, intermediate, or high risk. If they have 2 or more of those 3 risk factors, and they are considered high risk by this Mayo 2220 and would be eligible for this trial. And then this is where it kind of casts a larger net to include other patients that are considered high risk outside of these models. So patients could also be eligible if they have greater than or equal to 10% plasma cells in their bone marrow biopsy with any one of the following. So if they have an M spike or an M protein in the blood that's greater than 3 grams per deciliter plus that 10% plasma cells, they would be eligible. Patients that have an IgA isotype, so there are different isotypes. There's IgG, IgM, IgA. If they have IgA isotype plus the 10%, they are considered higher risk. They have a presence of immunoparesis, which again is a reduction of the levels of the immunoglobulins in the blood. If their free light chain ratio is greater than or equal to 8, then this would also categorize them as high risk. Important to note that if it's greater than 100, so it has to be greater than 8 but less than 100, because if it's greater than 100, then that would place them in the category of multiple myeloma. That would be considered a myeloma defining event. They have a progressive increase in their M protein and their M spike. So if we're checking their M spike regularly and we're seeing a progressive increase in that M spike, Each time that we check, that would classify them as an evolving type of smoldering myeloma and puts them in the high risk category. If they have 50 to 59% bone marrow plasma cells, so if we do a bone marrow biopsy and we see 50 to 59% plasma cells, this makes them high risk. As we know from Dr. Kazandjian's talk and earlier on the slides, patients that have 60% bone marrow plasma cells are that meets diagnostic criteria for multiple myeloma. So this 50 to 59% is right on the border. So that's why those patients are at higher risk. If they have an abnormal plasma cell immunophenotype, a large number of, excuse me, if they have an abnormal plasma cell immunophenotype and reduction of greater than or equal to one of the involved immunoglobulins, again, this is another, this in combination with the 10% plasma cells would put them at higher risk. If they have high-risk cytogenetics, so what this means is if when we're doing testing to look at the cells on a chromosomal level, if we're able to identify some of those abnormalities that are associated, have been associated with poor prognostic outcomes, so if they have the presence of any of those higher risk cytogenetics on that testing, then they would be eligible. They have increased circulating plasma cells, so a higher number of plasma cells circulating within the blood. And then if they have an MRI with any diffuse abnormalities or one focal lesion and or a PET CT, a full body PET CT with a focal lesion without any lytic bone destruction. And without the lytic bone destruction is kind of the important part on this with the PET CT, because the B in CRAB criteria stands for bone destruction, and that would put them that would upgrade their diagnosis to multiple myeloma. So they can have the presence of a focal lesion on a PET CT, but if there's any sort of bone destruction, then that would exclude them, because that would mean that they have multiple myeloma and no longer have smoldering myeloma. All right. And I think that's the last slide I had specifically on that. I kind of wanted to just touch on the highs, the treatment regimen, as well as the inclusion and exclusion criteria. I think this is a very exciting trial option that we have available for our high-risk patients. We know, teclistamab and daratumumab we're using for daratumumab we're using for newly diagnosed patients or patients at first relapse. Teclistamab we're using in the relapse refractory setting. So we know these are medications that work really well in the multiple myeloma patient population. So applying that to these patients that have smoldering myeloma, we're very excited about the potential to continue treating patients on this study and the promise that this offers from a treatment standpoint for these patients in the future.
Thank you so much for this presentation. It was really interesting. I learned a lot about this new clinical trial. We have some questions. Is this trial only in Miami?
I can take this one. Yeah, this is a single center investigator sponsored trial. This particular trial is only being conducted in Miami.
Perfect. Are there any studies showing that diet can help keep MGUS from progressing? Thank you.
You want to take that or you want me to? Go ahead.
I don't know if there's any. I think there's a lot of, anecdotally patients have some there's, been reports and things of diet associated with, various types of cancer. I don't know if there's any published studies available on that. I don't think so. Like I said, a lot of the evidence is somewhat anecdotal at this stage.
So in general, if I can just add, in general, nutrition-based studies are very difficult to conduct, and most of them are flawed, actually. And it's kind of it's like very difficult. So, but again, I think that's diet. I think what has been a long known sort of associate, I'm not going to say cause and effect, but association has actually been obesity and development of MGUS and other conditions.
I think Dr. Shaw has the intervention study, but I'm not sure if it's like the details about it. But for the patient who ask that question. If you want to contact me after the event, I'll try and share more information.
So I was
Um,
gonna talk about, so I don't know if we want to go through all the questions, but I think you know, if there are people who are just not in Miami, and I think, smoldering myeloma trials are very difficult if you're out of the city, because it's kind of, for obvious reasons. Most people want to be able to live their life. That's why they want to get their smoldering myeloma treated. But nevertheless, I can tell you. So obviously I'm biased, but around the time that I transitioned from NCI in Washington D.C. to Miami, I had written, and now my collaborator who's at the NCI is conducting a study that actually uses daratumumab like our study, but instead of in combination with a bispecific, it's in combination with Kyprolis. And so that is a study that's available in Washington, D.C. It is up and running. I think there's been about a dozen patients enrolled, plus minus. And that regimen is actually approved, FDA approved in the relapse refractory setting. But the one, and I bring this up, I think it's important because one of the beautiful things about getting treated at the NCI and the NIH intramural program is that, they quote unquote, your taxpayer dollars are very generous because patients will get flown and covered with stipends, etc., directly from the NIH in order to be on the clinical trial. So if geography is an issue for financial reasons, that's something to keep in mind. I think it's a very good regimen, so I wouldn't think of it less. And then in terms of immunotherapies, I'm sure there's other ones, but what I'm aware of is there is a teclistamab. I think it's plus minus. It's teclistamab monotherapy for now, I believe, at the Dana-Farber, which is probably what you were going to mention. And Dana-Farber also has a CAR T therapy for high-risk smoldering myeloma. Other than that, there are phase 3 studies that are multi-center, some daratumumab and isatuximab combinations. And so those are the trials that, but if you're close, if you live in Boston, I think you can go see Dana-Farber. They may have those, but otherwise, those are the three I would discuss. 3 centers, I guess. Unfortunately, they're all on the East Coast. I don't know of anything going on in the West Coast.
Okay, thank you. Yeah, two of the other questions were, what if I live in Australia, and the other was, I think, North California or something. But yeah, we have another
Those are
question that's,
challenges, unfortunately.
yeah, it says, if I don't live in Florida, how often do you need to go to Miami for this study? Is that possible? If like someone can apply?
It's possible, but I'll let Kellye sort of expand.
Yeah,
Okay.
so the treatment regimen, yes, it is possible. However, it is, for the initial dose of teclistamab, the monoclonal antibody, patients are admitted for safety purposes for about a week or so for monitoring for that first dose. And then the treatment itself is weekly. So it's it requires frequent visits for treatment and monitoring blood work. We very closely monitor these patients. So in addition to the treatment itself, there's also physician visits, blood work, and things that we're doing. So I think it would be very difficult depending on how far someone lives. It's feasible, I guess, in certain situations, but I think it would require a lot of travel.
Yeah, so Kellye is 100% right, and appropriate, but I'll say what I'm not supposed to say right now. And that is, because this, you didn't hear it from me, although I think it's hard when 200 people are logged in, but I will say there is an amendment going through that will decrease the frequency of the therapy. So really the involved part will be the first month. But after that, if all goes well, again, there's no guarantee this is going to happen, but the plan is to have the protocol modified so for monthly administration. And so one could definitely, if they have the financial resources, of course, come on a monthly basis is not completely unrealistic, I guess, depending on, we do have an international airport in Miami.
Yeah, for sure. Okay, we have an interesting question. It says, after the trial, what's next for the patients as far as treatment?
I think that would depend on what if they had a response to treatment, if they were MRD negative after completing the 2 years of treatment, it would likely involve just monitoring. We do blood work frequently to monitor for any signs of progression. We haven't had any patients that have gotten that far in study yet, but
Yeah, I echo what Kellye says. The study is actually 2 years long, and maybe by the end of 2 years, we'll know more. But I think it's a great question, and I think it's a challenging question, even with some of our older studies, like the one that I said is sort of, if some patients, require treatment for multiple myeloma, well, that's easy. I mean, because you know what to do, but patients who don't, we really don't know. I mean, on the same token, even for relapsed refractory myeloma, we don't know how long we should be treating patients with bispecific antibodies. And we actually have a few patients that are already on it for a couple of years and who may be in remission. And I think that's sort of evolving knowledge and data.
Yeah, that's interesting. We have another question that says, what % of your patients in the studies are African American?
That's a great question. So do you want to answer it, Kellye?
no, go ahead.
I think approximately 15%. I don't have the numbers in front of me. Our catchment area is in particular, obviously, Latinx patients, and our Latinx population is probably 60% on our trials. And it becomes very challenging because we're really now starting to see that, Latinx population, they're not all the same. And there's a lot of what we call genetic admixture, where there's different levels of, African compared to Caucasian sort of genetics. But anyway, sort of self-identified is probably about 15%. The majority of our patients are probably Latinx.
Oh, okay. We did KRD study show an increased OS or an increased PFS?
Yeah, these are great questions. So progression-free survival, PFS, just for those who may not know, is the time to progression or death. And then OS is basically the time to overall survival or death, basically. Those you really cannot say if it increased or decreased that in a single arm study. Time to event endpoints, they can only really be evaluated in a randomized fashion on the study. But everyone still wants to know, right? So, in the KRD study, if we look at the progression-free survival, and this time it's not progression of myeloma, but actually progression from smoldering to multiple myeloma. Again, I don't remember the exact numbers, but at about 8 years, somewhere between 70 to 80% had not progressed. So if we look at historic numbers, as Kellye mentioned, at 5 years, it's about 80% progress. So we're talking about 8 years, 70 to 80% do not progress. But again, I would take that with a grain of salt because can't really, it wasn't a comparison study.
Yeah. Every case is different. We have another question. Is it 414 considered high risk for the trial?
Yes. Yeah, 414 is one of the high-risk cytogenetics per the trial.
Okay, perfect. Thank you. Another one says, are the side effects profile better than the KRD NCI study?
It's an excellent question. Actually, I was gonna say maybe Kellye, you want to expand on some of the toxicities of this and kind of what we see and things, and then maybe I can sort of answer that question more directly.
Sure. So I think the main things we think about with teclistamab as far as side effects. So the reason that patients are monitored, as I said, teclistamab requires inpatient admission for the first dose of treatment, and that's due to a very rare but potentially serious side effect called cytokine release syndrome. And again, that's very patients don't usually, if they experience that, it's usually very mild. It usually is not severe, but because of that risk, patients have to be monitored inpatient. I will say the patients that we've treated on this trial, we've not had anyone that's had any severe cytokine release syndrome. And then if that's going to happen, it usually happens with the first dose, and it doesn't happen with any subsequent doses. As far as with other doses after the fact, the main one of the main side effects we think of is risk of infection, which all myeloma patients are typically at higher risk of infection, especially when they're on treatment. But we know, because we have some experience treating with teclistamab in the relapse setting, we kind of know how to combat that a little bit. So we will typically start these patients on prophylactic or preventative doses of antibiotics, antivirals, things like that, to kind of mitigate that risk of them developing any sort of infection. And then the daratumumab, the other medication, that usually is very well tolerated as well. We don't see usually a lot of side effects with that. Sometimes patients can have a little bit of kind of like a delayed reaction to it with the initial doses, but then your body essentially gets used to it, and that goes away. And then patients usually do pretty well with that medication.
Okay. Thank you for your answer. We have another one. After the study is completed, how long does it take for the FDA approval so it is available to all without being in a trial?
Dr. Kazandjian, I don't know if you have a...
Yeah, I can answer that. I was just looking at the questions. I just realized that I can see them also. Well, can you repeat that?
Yeah. It said after the
trial is
study is
completed.
completed, how long does it take for the FDA approval so it is available to all without being in a trial?
It's a great question. So in general, you need, in oncology, in other indications, it's usually 2, but in oncology, for regular approval, you need a well-conducted randomized clinical trial that is sort of really outside of the scope of an academic institution conducting. So you're asking specifically for this indication and the trial that we have. This is really what we call fact-finding and exploratory in nature. And statistically speaking, again, you can't really, you really need a comparator arm in a randomized study. However, if at the end of the study, if the signal is strong enough that this works, then it may lead to the companies to sponsor, or even maybe the cooperative groups and the NCI to sponsor a randomized study to prove that this regimen in high-risk smoldering myeloma is both safe and effective.
Okay, perfect. Thank you for your answer. Yeah, we still have a couple of questions. Do you have
You want me
time
to go
for?
through these maybe real quick? So,
Yeah.
because I know we're running out of time, I may be able to make this quick.
Yeah, that's easier.
And it just, Kellye, I don't mean to take over, but please do
No.
put give your input.
Go ahead.
So on my list, I'll see how is multiple myeloma and MDS related. So MM stands for multiple myeloma, MDS stands for myelodysplastic syndrome. MDS, myelodysplastic syndrome sounds a lot like multiple myeloma, but it's not related at all. Actually, it's a sort of a pre-malignancy or a pre-cancer to, or cancer, some would say, to acute myelogenous leukemia. It's indirectly related that we think in our group, we found too that some therapies could actually lead to it. So especially like alkylating therapies, they're called. So old-fashioned chemotherapy. And then I think the verdict is out. There are some associations that patients with hematologic abnormalities, sort of, including MGUS, may be at a higher risk of having other hematologic, but purely biologically speaking, they're not related. Okay, I have smoldering myeloma for 15 years now, and so far my labs every 3 months have been stable. I'm turning 60 this year. Would the progression increase as I age? So far, I am healthy. It's a great question. We don't really know. The thing is, when you first get diagnosed based on the old studies, your highest risk of developing full-blown myeloma was during the first 5 years. So I think you're doing well. I think probably what you have is more of what I would call it MGUS-like phenotype or an MGUS-like natural history. But even with MGUS, that risk has to be reevaluated on at least at a yearly basis because certain things could happen and that could take off. But it sounds like for the most part, you're probably doing well. You know, there have been models that the English modeled this once that they said if people live long enough, all of us would develop MGUS at a median age of 150 years old. So if you live long enough, if you have MGUS, at some point, probably you're going to develop it. The question is if you live long enough. All right. I don't know if you wanted to add anything, Kellye.
No.
All right, how do you decide when a high-risk smoldering patient should start a trial? I have 1Q making me high risk, but my numbers have remained relatively stable for over 3 years since diagnosis. My myeloma doc has recommended I do not try it yet because of this. I'm curious about your decision process. Do you want to add to this, Kellye? You see this a lot, right, in clinic?
Yeah, so I think that this is a lot of this is centered around some patients really want to start treatment. So a lot of it is involving the patient in the decision making process, and I think it depends on if the numbers have been stable, meaning no increase, or if there's been slight increase. I think it always has to be a discussion with your physician and how much you're potentially wanting to pursue treatment, and then how stable or borderline your numbers maybe are. The high risk cytogenetics, this trial takes into account things like 1Q gain and things like that. But there are, of course, when we're looking at patients to potentially enroll in a trial, we're looking at not just the numbers, but the patient as a whole, and we're looking at everything, the big picture. It's a lifestyle change, so I think it really depends on you and that discussion with your healthcare team.
Yeah, I agree. Or do you think free light chain ratio of 100 will go away? I don't know. I think we need more data, and I think it's very difficult to say. And I don't really, I don't have a comment one way or another. I think time will say with the incoming data.
Yeah.
Is lambda free light chain only smoldering at any greater risk for either myeloma or amyloidosis than smoldering, which is not only free light chain, and likewise does lambda free light chain myeloma have a distinctive? As far as we know, the risks are about the same. Obviously, most amyloidosis, it's a light chain component that you need, but really, I don't necessarily think we know that one is at a higher risk than the other. What does abnormal plasma cell immunophenotype mean? I understand what the decreased uninvolved IGS means. So when bone marrow biopsies are looked under the microscope, at the same time, usually the liquid part of the bone marrow is taken and a technique called flow cytometry is done. Then that flow cytometry, they look at different typical normal antigens or things that stick out of this myeloma cell. And myeloma or plasma cells, which is the normal cell, the abnormal cell, the plasma cell has that abnormal, and that's what the abnormal immunophenotype would mean. I have heard during other programs that if a patient does bispecific treatment, then using CAR T later is less effective. What are your thoughts about sequencing? Yeah, again, great question. I think we're still learning about that in the relapse refractory myeloma setting. So I have no idea in the smoldering myeloma setting. My gut suspicion is, if you go after the same target with both the CAR T and the bispecific, and if you give one right after or before the other, then sure, I think most patients are not going to do as well. But if there's a pause in between, I think they will be more effective, or if the target is different. Well, first, I think we have to see if it is reasonably safe and effective based on this exploratory data in smoldering myeloma with these teclistamab studies, and then I think we can think about some of these other questions. Do you want to add anything to that, Kellye?
No.
All right. Do you have a sense that we are within 2 or 3 years of reaching a new stage? Yes, that's an easy question. I do feel so. How do you know if you have anemia? Well, anemia is really easy. It's most people, have, at least I feel what the exact primary care guidelines are, but at least every 6 months or 1 year will have a complete blood count by their primary care doctor. And in that there's two values, multiple values, but a hemoglobin and a hematocrit. And if that's low, that would suggest you had anemia. Should anyone diagnosed with light chain MGUS have a bone marrow biopsy to tell if they are in smoldering myeloma? I think most patients will. I didn't say this yet, which is a surprise. What I usually say with all these meetings, the most important thing are not the details of our presentations or the questions. The most important thing, if you get one thing out of this virtual webinar is that you need to, if you have any of these diagnoses, you have to see a myeloma expert. Okay, not like an oncology expert or general hematology expert, a specific myeloma expert. That's all they do. And really that's the most. There are just so many caveats. We can't learn all this, it's taken me 15 years and I still learn something new every day. So I think to be more palatable, that's the most important thing you can do. But to answer this question, should everyone die? No, I mean, not everyone with light chain MGUS gets a bone marrow biopsy. Again, I don't want to confuse this too much, but sometimes people are even misdiagnosed, and that's why I said what I said, misdiagnosed with light chain MGUS. There are certain parameters and light chains that we check are composed of both normal and abnormal light chains in the test. So you really need to see an expert, and if it's low risk, you potentially would not have to get a bone marrow biopsy. What if people were willing to move to the location of the trial temporarily, even from Australia? Do it, and yes, you should come over. Australia is, I don't know what the weather in Australia is, but I think it's sunny, so you definitely feel at home in sunny Miami, except for today where there's like lightning. But in general, yes, we can do that, and there is a international medical department, so to speak, at University of Miami. How many patients do you have in Revive, and how are they doing? Our patients are doing quite well. We have about a handful of patients, and no major side effects so far. Can I come in for screening only? Is there a compensation for travel? I'm not quite sure what that means. Can I come in for screening only? Do you know, Marisol? Or
I think they were referring if they can come to participate in the trial, even if they don't live there. But I don't think you have a compensation for travel, right?
There's
They
no
have to cover their own. Yeah.
No, there would not be any compensation. If you don't, I mean, I would actually answer the reciprocal of that question, that if you're not sure if you would qualify, you could basically always have a telehealth visit with us. You could send us all your information that you've had done so far, and you know, the team, Kellye does this all the time, could what we call pre-screen to see if it's something that would be reasonable option. What is considered Latinx? Well, I think Latinx, I'm not an expert by far, but I've been educated that sort of the more current term to Hispanic, what we would traditionally call Hispanic, is really Latinx. So that's what I try to use.
Okay.
If you were MGUS for over 15 years and then it turned to smoldering, does that give you a better chance at not turning? No, I don't think it goes one way or another. I did the RVD in New York City for 2021 and now in remission. Do they still use Velcade? Yeah, many people still use Velcade. Again, and not so much. I don't. There is, I think, there is the VRD. There's a DARA VRD study, I want to say, in smoldering myeloma.
Okay.
I was diagnosed with smoldering in 2012. Are there any studies for someone having smoldering for that long with intervention required? Is it something that may have interest at another time?
He added a follow-up question later that says, I meant no intervention. So he was asking, are there any studies for someone having smoldering myeloma for that long with no intervention required? Is it something that
Yeah,
may
we
have?
do. Yeah, we have the study. Kellye, do you want to?
No, go ahead. Go ahead.
So we have, so again, like I was saying, our genomics team is really, we're trying to really knock down what are the genomic blueprints in patients with MGUS and smoldering. And so we have what's called the Transform study, which is a non-interventional, meaning you don't get any drugs. But basically, you would get your standard of care bone marrow biopsies and PET-CTs like you would normally, but you, by consenting on the trial, you would give us consent to get to keep an extra sample and to review your clinical data, where we would actually run the genomics eventually to try to validate the genomic blueprints that we have for smoldering and multiple myeloma. I was diagnosed with multiple myeloma mid-21 and was treated with DARA drug bags, which put me in remission quickly. I have been on DARA maintenance 2 years. Will your study results apply to people in remission? Unfortunately, not so much. It's a kind of a different treatment. Yeah. Did you want to say something, Marisol?
Yeah, that I'm not sure if they can all see the questions, so that's, so if, do you want me to read the
I was
rest of the
diagnosed with
question
multiple
aloud?
myeloma. Did you want me to read it out loud?
Yeah, I can read it if you want to, but I'm not sure if everyone is reading the question and they won't know what the answer is related to that question, because I don't think they all have access to see the questions.
All right, I was diagnosed with myeloma mid-21 and was in 2021 and was treated with DARA, Revlimid, which put me in remission quickly. I have been on DARA maintenance for over 2 years now. Will your study results apply to people in remission, such as myself? I think it's very difficult, I was saying, because it's a different regimen. To follow up on my initial question, if a patient completes the 2-year regimen MRD, I guess, and becomes MRD negative, they will not be on maintenance meds. Is that correct? That is correct. Thank you. I have not had a bone marrow biopsy since diagnosis, only labs follow-up. Can I request for another bone marrow? Of course you can request. I don't know if anything is changing. I mean, you can request it. I think that's an important conversation to have with your doctor. Believe it or not, some patients still believe that clinical trials mean one group gets the good stuff and others get a placebo. Is this Florida, Steve? Maybe, I don't know. Can't you change the name? Maybe more will volunteer for the study. Yeah, maybe. But to the point is when I kept saying phase 3 randomized, those are the trials that people think, oh, some people get the good stuff and some people get placebo. Depends on whether you like drugs. people who don't like drugs will say some people get nothing and some people get toxins, right? So, in fact, there are different trials, and some are what I call single arm studies, traditionally known as phase 1 and 2 studies, that all the patients on it get the same treatment, and you know what treatment you're getting. It's not blind. In oncology, quite honestly, it's very rare to have, number one, a placebo-controlled study, and number two, a fully blinded study where you don't know what you get. Because even if no one tells you, you know from just the side effects. All right, I have smoldering and was diagnosed December of 2019, progressing slowly. My issue is I keep getting pneumonia, even though I have never been around smoke. Is pneumonia common among smokers? Again, great question. So, it's kind of historically, it's really interesting. Before the revised diagnostic guidelines in 2014, actually recurrent infections was one way of diagnosing full-blown multiple myeloma. It's like one could call a minor criteria. So myeloma itself, in some patients more than others, causes some immune incompetence, and that may have something to do with it. I think again, some of those you can find in the laboratory, like if you had decreased normal immunoglobulins or decreased normal antibodies. But in others you can't really identify, and again, that's something to discuss with a physician. But I just want to put this out there that I myself am seeing in non-myeloma patients a lot more people sick. I think post-COVID people just get sicker, right? Because we're just being exposed more. So I would take that. I'm not saying that's what it is, and I don't mean to belittle if that's in fact what's going on, but just that. I myself, but it could definitely, be related to the smoldering myeloma.
Thank you for answering all the questions. I know we
I
have
can't believe we made it. I think it's the first time I've ever gone through all the questions.
I know. I was like, I hope we don't run out of time, but
Oh my God, I spoke too soon. I presented with both ITP and smoldering. How common is this? It's not very common. Sorry, Marisol, why don't you close it up before we get more questions? Okay.
Yeah. Yeah, that's perfect.
Kellye and I are more than happy to answer any questions, especially by email. So you definitely share our email, and we're happy to answer anything offline.
Yeah, perfect. I'll share your contact in our follow-up email. As well as share the myeloma specialist directory we have, so they can try and find a specialist near them in case they don't live close to Miami.
Sure.
But yeah, thank you so much for your time. It was really interesting. Do you have any other comments?
Find a myeloma specialist if you don't have one.
Yeah. Okay, thank you so much for your time. I'll share my screen again and give our outro announcement. So
okay, take care, everyone. Thank you for the questions, and keep it
Thank
exciting.
you, guys. Thank you so much for logging in.
Thank you. So everyone who is still here, our next meeting will be in August. I don't have a specific topic yet, but as soon as we define this, you'll receive our usual promo emails. And we have 4 upcoming events. One, it's on Thursday. It's a Black Myeloma Health Community event, and we'll talk about communicating effectively with your healthcare team. On the 2nd, we have our first HealthTree Cure Tour. If you haven't heard of this, we will have in-person meetings where we will talk about research, and we'll have like a workshop to help you contribute to finding a cure faster. So the first one will be in Syracuse on May the 2nd, and then, then on the 7th, we'll have the financial event, our monthly meeting, and bi-monthly meeting now. And it will be about how to change your lifestyle to reduce spending. And on Wednesday, the 8th, we'll have the non-secretary event. And we have a smoldering myeloma survey that it's a different way of contributing to research if you're not eligible for a clinical trial. So if you want to participate answering the survey, you just have to connect your records to CureHub, and we have a team who can help you step by step. So I'll add the link as well to our follow-up email. So in case you want to participate, another thank you to our sponsors, Regeneron, Sanofi, BMS, and Johnson & Johnson. And thank you all for being part of this meeting. Hope you have a great rest of your day. Bye-bye.